So surgery for invasive anterior mediastinal tumor. Now, everybody knows anterior mediastinal. If you have a CT scan with a anterior mediastinal tumor, what is the differential diagnosis? Give me the 4 T's. 4 T's. Anybody come in?
Thymoma.
Okay. One thymoma.
Teratoma.
Teratoma. What are the 4 T's?
T-cell lymphoma. T-cell
Lymphomas.
lymphoma.
Thymoma, teratoma, T-cell lymphoma. And 4th T?
Goiter. Retrocell goiter.
Thyroid.
Thyroid mass. Okay. So remember this. In the exam, whenever you have a CT scan with anterior mediastinal mass, never ever give a diagnosis. Always give a differential diagnosis. That is the mandatory thing. Because when you start off looking at a CT scan, you never know what the diagnosis is. Anything can change. So never give a diagnosis. Always give a differential diagnosis. And then you say, I will conduct investigations to identify what is what. And the best investigation is, of course, either a CT-guided biopsy or a true-cut biopsy. Okay? We'll talk about that in a minute. So the commonest thing that we see, somebody's phone is making a funny noise. Who is this? Guys, somebody's phone is making noise. Can you just switch off? Just mute your phone. Somebody's phone is making a horrible noise in my ears. Yeah, it stopped now. Okay, good. The commonest thing that you see in the anterior mediastinum is, of course, thymoma. Okay, all of us, we have seen thymomas and we know about it, and I'll talk about it in a bit more things. You can have thymic carcinomas, or you can also have germ cell tumors. Now, I'm talking about malignant tumors. Okay, I'm not talking about benign stuff. So we are today going to talk about surgery for invasive anterior mediastinal tumors. And the commonest malignant tumors that you see are either thymoma, thymic carcinoma, a germ cell tumor. Okay. If ever you have to talk anything in an exam about thymic surgery, you must, the first line must be according to ITMIC. Okay, please make it a second nature. And please go out there and read the ITMIC guidelines. The website is itmic.org, O-R-G, itmic.org, and there are all the guidelines for thymic management. So all the guidelines are very clearly placed. This is a group of surgeons across the world who have specialist interest in thymic surgery, and they have come together and we all contribute our data to this society. And then ITMIC comes out with guidelines on how to manage thymic disease. So whenever you answer a question on surgical management of a thymic tissue, you must say according to ITMIC guidelines. Whether you know it or don't know it, just say it, because chances are you'll be right, and chances are that you know what you're saying corresponds with what the ITMIC says. Because what I'm going to tell you is very standard things, okay? So once you go through my lecture, you will understand. Okay, so let me just come on to the guide. So before we do that, we have to understand how do you stage thymomas. Okay, and the best way is to understand the pathological staging of thymomas. So we all know there is stage 1, stage 2, stage 3, and stage 4. That's the basic concept that you have to understand. So stage 1 is when there is a tumor which is well circumscribed. The capsule is completely intact, okay, and there may be or may not be some capsular invasion. Can you see that? But it has not gone beyond the reach of the outer margin of the capsule. Okay, that's stage 1, always. So the outer covering is intact histologically. The inner covering may be breached, the inner margin may be breached, but the outer covering is still intact, and that is called as stage 1 carcinoma, stage 1 thymoma. Stage 2 is when the outer covering is breached. Can you see this? Look at this where my arrow is. The outer margin, the moment the outer margin is breached, then it becomes a stage 2A. In a 2A, it is limited microscopic transcapsular invasion. So you don't see it with naked eye, but under a microscope, you are able to see that it has gone beyond the outer margin of the capsule. With 2B, it has gone beyond the outer margin of the capsule, but it is still limited to the mediastinum. Okay, guys, switch off your phones. There is too much noise, background noise. Switch off your microphone, everybody. Only switch it on when you want to talk, because it's my ears are ringing. Everybody just switch off your microphones, okay? Stage 2B is when the outer margin has been breached, but it is not microscopic, it is gross invasion. So you can physically see the tumor gone, but it is still limited to the mediastinum. So come back to 2A. 2A is microscopic invasion of the outer margin of the capsule. 2B is gross invasion of the mediastinal fat, but limited to the mediastinum. This is important. Stage 3 is when there is direct mediastinal involvement of the pleura, of the partial pericardium, or the vessel invasion. So can you see that? Pericardium, there are 2 layers. There's the fibrous layer and the serosal layer. So there is invasion of the fibrous layer. That's why it's called as partial pericardial invasion. So it is still stage 3. The vessels are invaded, commonly the SVC. Pleura is invaded. This is the pleura. Can you see this? So the mediastinal pleura is invaded. Yeah? Not the visceral pleura. The mediastinal pleura is invaded. I'm showing you these pictures because it's important to understand the differentiation. And then stage 4A is when tumor of any size has infiltration beyond this into the serosal part of the pericardium, into the vessel, into the parietal pleura with multiple nodules. Can you see these distant nodules? But still everything is limited to the chest. And stage 4B is when it is gone extra thoracic. That means either it's in the liver, or it is within the substance of the lung, or it is gone into the lymph nodes. Can you see that? So distal organ involvement, nodules within the parenchyma or within the lymph nodes, distal lymph nodes, okay? So I'm going to go through this again. It's quite important because prognosis changes depending upon the stages. So stage 1 is there may be some invasion of the pericardium. There may be some invasion of the capsule, but it has not gone to the outer margin of the capsule. Okay. Stage 2A is when it has gone to the outer margin of the capsule. It is microscopic. It is not macroscopic. Stage 2B is when it has gone macroscopic invasion, but still limited to the mediastinum. Stage 3 is when it has gone into the pericardium, but limited to the fibrous layer of the pericardium, not involving the serous layer. When it has gone to the vessels, or it has gone to the mediastinal pleura, but not yet gone into the lung. This is the visceral and the parietal pleura. And stage 4A is when there are multiple nodules on the pleura, but nothing in the lung as yet. There are multiple nodules on the pericardium. And stage 4B is when it has gone outside the thorax, or it has gone into the substance of the lung. Okay. So this is important to understand the various 4 stages. So there has been lymphatic or hematogenous spread. This is hematogenous spread. This is hematogenous spread. This is lymphatic spread. Okay. So when there is a lymphatic spread or hematogenous spread, then stage 4. Okay. WHO has a different classification. This is something which you just have to learn, and we'll talk about it in more detail later on. But A, AB, B1, B2, B3, and C. So this is a WHO classification, and I won't talk about this more because I want you to understand the concepts of management. So let's leave this for the minute. This is the most important slide. I'll tell you why. The reason why this slide is because it tells you why you must offer surgical resection or why you must offer treatment to these patients. The reason why you must offer treatment to these patients is because survival is related to the stage. And stage 1 is 96%, 5-year survival. Stage 2 is 86%, 5-year survival. Stage 3, which is invasion of the pericardium, invasion of the vessels, still has a 69% 5-year survival. And more importantly, stage 4 has a 50-year 5-year survival. So no matter what you do, you must try and give treatment for these patients. There should be no patient with a thymoma which you do not treat, either with chemotherapy, radiotherapy, surgery, or a combination of them. But the reason you treat is because even people with stage 4 have about a 50% 5-year survival, provided you treat them, of course. So that's the key thing, that you must try and treat. If you do not take away anything from this whole lecture and you just take away this slide, I think my job is done. That even if you have a stage 4 thymoma, do not give up on the patient. You actually must try and give them active treatment so that you can promote survival for these patients, because stage 4 can have a 50% 5-year survival if caught in time and treated properly. Okay. Now 20-year survival is different. Stage 1, 2, 3 is pretty decent. Even stage 3 has got a 49% 20-year survival according to Masaoka. Stage 4s don't live that long. But even if they live for 5 years, for God's sake, that is definitely acceptable. And that is why you will find that a lot of thymic surgeons are agreeable to do radical surgery. They're agreeable to take down SVC, take down this, take down that, purely because the survival of these patients is very good. And most of the times, these are young patients. And because they are young and fit patients, you try and give them the benefit of doubt by offering them surgery in combination with other treatment modalities. Okay? So very, very, very important. This is the most important slide. Remember this. So if you ever get a patient with thymoma, do not give up and do not say, sorry, we cannot do anything for you. You must try and downstage the tumor, give him chemotherapy, whatever is the protocol. We'll talk about that in a minute. But you must try and treat him. And if possible, make him surgically fit so that he can withstand your surgery. Okay? Very important. So what are the treatment options available to us? Stage 1 tumor, there is no doubt about it. The treatment is surgical resection. If anybody offers anything else besides surgical resection, it is criminal negligence. Do not let your chemotherapy guys give chemotherapy for stage 1 thymomas. You must always offer surgical resection because you can give them a 96% 5-year survival and an 86% 20-year survival. So it's very, 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 very important. But the same thing you've got to remember is, a lot of people ask me, should we do biopsy of these tumors? And should we do this by minimally invasive techniques? Okay. So let me just go back one stage, okay? Just one slide before. The reason why a lot of us get very edgy when you talk about doing a minimally invasive technique for a large tumor is because it's all about the capsule. If you breach the capsule and you seed the tumor cells into the mediastinum, then you convert a stage 1 tumor into a stage 4 tumor. Do you understand that? A stage 3 or a stage 4 tumor. So something that has got a 96 or an 89% 5-year and a 20-year survival, you have a potential of converting that into a 40%, a 50% or a 0% survival. And that is the issue here. And we'll talk about it in a minute. So when people say I did a 20 centimeter thymoma by robotics, you are not taking the risk. The patient is taking the risk. Because today you will do the surgery and get away. These are slow growing tumors. The metastases will happen, 10 years down the road, 5 years down the road, and something that could have had a 96% resection and survival rate will unfortunately drop down to 50% because you breached the capsule during surgery. And so this is the philosophy that you have to keep in mind when you talk about large thymomas. I do a lot of these surgeries and I do offer minimally invasive surgery. But more and more, I'm starting to think that really the risk is being taken by the patient, not by me. And it's not fair to the patient. So when we talk about discussion of what treatment option, this slide comes into the mind, and remembering that, you know, a tumor breach is a capsular breach is not a good thing for these patients. But by the same token, an FNAC or a true cut biopsy has not proven to change the prognosis of these patients. So that's why we still do an FNAC biopsy or a tumor biopsy of an anterior mediastinal tumor without worrying about capsular breach, because a small percentage of these tumors turn out to be lymphoma. And if they turn out to be lymphoma, then surgery is not the answer for these people. Because if you give chemotherapy to lymphomas, they respond beautifully to chemotherapy. So surgery is not an answer for lymphoma. And that is why we prefer to have a preoperative biopsy in a large mass. In a very small 1 centimeter mass, we may not biopsy, we just take it out, okay? So let's just carry on and talk about it. But this is the philosophy why people worry about this. So stage 1 surgical resection, quite clear. And now I'm talking purely about treatment, okay? I'm not talking about management and all that. Stage 2, what is the option? Stage 2 is still complete surgical resection, but wait for the histopathology to come back. And when the histopathology comes back and shows that there was microscopic invasion of the capsule or macroscopic invasion of the fat, then I send the patient to the radiation oncology and I offer him an option of undergoing post-operative radiotherapy to the mediastinum. Remember, these are young people. They are going to live 20, 30, 40, 50 years. And the last thing you want is a recurrence in the mediastinum post-surgery. That is why I send them to a tumor board and the patient needs the radiotherapy. If it is microscopic and the patient is old and fragile and he doesn't want radiotherapy, that's fine. But if it's a stage 2B, I'm a little more uneasy about not offering them radiotherapy. I would prefer them to have radiotherapy so that long-term survival is better for these patients. Stage 3. Stage 3, it is complete surgical resection, but definitely post-operative radiotherapy. Okay? Stage 4 is surgical debulking, radiotherapy, and chemotherapy. And which order you do it, I'll talk about it in a minute. Okay? Just hang on. Don't get put off by the word surgical debulking. Okay? Because in cancer surgery, you do not do what is called a surgical debulking. So don't get put off by that word. I will come back to it in a minute. Okay? Chemotherapy is used preoperatively to decrease the size to facilitate surgery. And that is the philosophy that we use in stage 4 tumors. Because we want to actually be able to do an R0 resection as far as possible, an R0 resection. R1, R2 are not good surgeries. And that is why we offer them preoperative chemotherapy. We restage them, we scan them, they get downsized, and then if they are operable, we offer them surgery. Okay? So this is broad principles of management. Everybody okay with this? Any questions on this?
No, sir.
Okay, good.
Sir, one question, please.
Yeah.
So I have seen some surgeons who would do thymoma by thoracoscopy, and then it will become totally smashed into pieces, and they take it out in pieces. So that will definitely cause tumor seeding, right?
Absolutely 100% right. And such surgeons should not be allowed to operate by VATS. Okay, I am a great proponent of VATS. I'm a great proponent of robotic surgery. But if it's a thymoma, I do what is called as a no-touch technique, where you do not touch the thymoma. That's why I do not do a thymomectomy. I do a thymectomy because I hold the fat around the thymoma and take it out. If you have smashed the thymoma, you have caused tumor seedlings. And the tumor seedling will happen in the pleura because you've come from the side. The tumor goes into the pleura. You don't see it, and then a few years down the road, you do a PET scan, you find tumor in the pleura. A stage 1 thymoma got converted into a stage 4B. The moment you get pleura involved, it's a stage 4B, 4A, 4B, and that's not a good idea. So that's why if you're going to do it VATS, you've got to be very good, and there are certain definitions which patients will qualify for VATS. So not all thymomas should be done by VATS. Anything that is less than 5 centimeters is good enough for VATS. That is what ITMIC says, that anything less than 5 centimeters, you're okay for VATS or robotic. Anything more than 5 centimeters, you are in dodgy waters. You should not try to do this by minimally invasive. But a lot of surgeons do bigger sizes, but they do what is called as a no-touch technique, and that is important. And then you put it into a bag and you take it out from a bag. Again, you got to remember the port through which you take it out has to be increased in size to accommodate the tumor to come out. So smashing a thymoma is a complete disaster. Should never, ever, ever be done. You are actually liable for criminal negligence if you do that. Okay, so what are the operative access? VATS and robotic is the one access. And in fact, now with the ITMIC guidelines coming in, this is the first time where they have said that early thymomas with smaller sizes can be operated by VATS and they get additional benefit, okay? So there is a role for that. The second approach is sternotomy, open surgery, open it wide, take it all out. The third is sternotomy and Hemi clamshell. The fourth is thoracotomy, right lateral or left lateral, depending upon the position of the tumor. And the fifth is clamshell. If it's a very large tumor involving vascular structures, etc., then clamshell. So this is a standard. Now the reason why I show you this picture is even though this was a non-myasthenic thymoma, this patient did not have a myasthenia. It was a non-myasthenic thymoma. I have done a complete thymectomy. I personally prefer to do a complete thymectomy for the simple reason that the thymoma is here, but I will hold this fat, okay, and I will dissect along the line of the fat. So I am not touching the thymoma. This is the key thing you've got to remember. When you go in by VATS, a lot of people grab the thymoma, pull it, push it and all that. That is not to be done. You must do it with a non-touch technique. That is why I personally do not do thymomectomy, because I find that when you're trying to do a thymomectomy, you actually grab the capsule of the thymoma and you pull it and you try to take it out. And that is not such a good idea. Okay. Now something big like this, you need an open surgery. It's stupidity to even try and put in a VATS camera into this. Now, in between, there is a group in which you can start with VATS. You can do a lot of dissection with VATS because the view is better, but you end up taking out the specimen by doing an open sternotomy or a thymomectomy. That is acceptable. You can put a couple of ports, do some of the dissections, and then open up from the other side and take it out. Or open up the sternum and take it out, and that is acceptable. Vincent Fang from Shanghai Pulmonary is recently just published a paper where he's talking about taking out large thymomas through VATS. And his experience has been that he's got good results, even though he's taking out big thymomas by VATS. But the problem is he is in a high volume center with high experience. If you're an occasional surgeon trying to take out big size thymomas by VATS, it's not such a good idea. So Vincent Fang and Walter Wieder are two people who do talk about taking out big thymomas. Even I have taken out big thymomas by VATS or robotics. But personally now, I prefer not to take it out. It's better to do a sternotomy and take it out and make sure that your patient lives a long time. Okay, it's the philosophy which is the problem rather than the technique. The technique is not an issue. It's the philosophy that's the problem. Okay. Now, when you have a big thymoma like this, okay, let's talk about VATS and robotics. Usually, tumor less than 5 centimeters are the ones that you take out. Any tumor with a local invasion into the pericardium is not a contraindication for VATS. Okay, almost all of us who do thymic surgery, we will very happily take out a patch of pericardium along with the thymoma and we can put in a patch repair or anything like that. So it's not a problem. Local invasion into the pericardium, into the fibrous layer of the pericardium is not a problem. If it is invaded into the visceral layer of the pericardium, then you have a problem. Then it has gone in, and that's not such a good idea. I always prefer to do a thymectomy rather than just a thymomectomy. And I personally visualize both pharynx and the innominate and clear it out of from all of them. Okay. The most important thing to remember is conversion to open is okay. It is very, very important. I want people to understand this, that this is not about doing it by VATS. It's about doing what is right for that patient. Okay, that's the most important thing. Always exploration of the pleura is important before you start doing anything more. So you put in a camera or you open a chest, always look into the pleura because you want to see if there is pleural metastases or not. Okay, it's quite important to at least document that there is pleural metastasis so that you can give post-operative chemotherapy, radiotherapy, whatever else you want to do. All specimens must be put in a bag, and it is important to examine the specimen for completeness of resection. And the ITMIC comes up with what is called as a thymectomy board. Okay, it's a board on which there is a diagram of the thymus, and then you put the put the specimen on the diagram, and you mark out what you have taken out, and you take a picture, and that picture is shared with the pathologist, so that the pathologist knows exactly what you have taken out. Okay, so the thymectomy board is quite important to use, particularly when you're talking with the pathologist. You need to tell them exactly what you take out, what is what, and so sometimes I put a marker at the tip, sometimes I put a stitch close to on the fat, close to the thymoma, so that they know what I've taken out. Sometimes I've taken out pericardium, and if I don't tell them that I've taken out pericardium, they will stage it wrong. They will think it's a fat. You don't assume that the pathologist knows that there is pericardium along with the fat, because it all looks like one mush to them. So it's important to communicate with the pathologist what you've taken out. I had a patient whom I did a thymectomy, took out the whole pericardium and sent it to the pathologist. And my junior forgot to write that there was pericardium with the specimen, and the report came back as stage 1. Okay, they reported it as stage 1 thymoma. And I had to go back and fight with the pathologist. I said, listen, this is not correct. The tumor had invaded the pericardium. I took the pericardium out. This cannot be stage 1. And after they had a look again, they changed the stage from 1 to 3A because I gave them information. So it's quite important to communicate with the pathologist. This is my standard thymectomy. We won't talk about this. This is how we do it. Our teams there, etc., etc., etc. I'm going to go over this. You don't need to see this. Or do you want to see this? It's just a 2-minute video clip. Let me reduce the volume. So this is our robotic thymectomy, how we stand and do it. This is not for thymoma. This was actually for a myasthenia. But for me personally, the robot is a beautiful tool because it gives me very good vision. It gives me excellent magnification. It gives me more mobility of the endorist of the robot. It is in the mediastinum that the robot really comes into its own. And I personally am a great fan of doing almost all thymic surgeries by robotics. If I have to do by minimally invasive, my choice is robotics rather than VATS, because the vision that you get with robotics and the maneuverability that you get, and more importantly, the ability to teach is very easy with robotics. I am much more comfortable when my junior is doing a thymectomy by robotics rather than when he's doing a thymectomy by VATS, because with robotics, I can control his every movement and I can get him to do the surgery more safely. That's my personal this thing. Now, this is another guy who had a large anterior mediastinal mass, and it was a germ cell tumor, and he had had previous chemotherapy, multiple chemotherapies, and recently on the thoracic group, my WhatsApp group, we discussed a similar case like this, And a case like this is stupid even if you try to do by VATS. That is really crazy. You should never ever try to do anything like this by VATS. So you go in there. This one I did probably by, I always make sure that when you're doing a complex case with a vascular invasion, you have to make sure there is cardiopulmonary bypass in theaters. Always. Because you never know when you might have to do an SVC resection. You never know when you might actually injure something big in the chest. So I always keep a cardiopulmonary bypass standby in theater. In the exam, when you're asked these questions, you must say it. In FRCS, what you're trying to see is how safe a surgeon you are. So don't insist on VATS. Say I would do it by open surgery. Even if it's a small tumor, say I'd do it by open surgery because that's my level of experience. If it's a big tumor involving vessels, say that I would have cardiopulmonary bypass standby in theater. These are signs which tell me that you're prepared for things going wrong, and that's important. I prep the groin, always. Whenever I prep for a complex thymic surgery, I prep the groins and keep it sterile because you never know when you might have to put in a femoral and femoral arterial and venous cannula and go on bypass. You never know. So that's why I always prep the groin. Remember these subtle points which I'm putting in. And the other thing is I always keep a cell saver in theater. Cell saver is important. And when you talk in an exam like this, if you give these points, it tells me that you're thinking about this surgery. And you're not only thinking about taking the surgery out, you're thinking about how to make it safe. What to do if there is a complication. And when you're in the mediastinum, you could very easily damage brachiocephalic vein, you can innominate vein, you can damage SVC. So it's always good to have these things in theater. I'm not saying you open it, I'm not saying you prime it, you just keep it ready, just in case you need it. This was that patient which we did. We did what was called as a Hemi clamshell. So that's a vertical incision and then going across like this. And I'll talk about that in a minute. I'll show you all the incisions that we can do. So this is a Hemi clamshell, and this gives you excellent view to the subclavian arteries, subclavian vessels, and also to the mediastinum. For me, the sternotomy is important. In the last case that we discussed in the thoracic surgery group, there was a lot of people who were saying that, sorry, just 1 second. A lot of people, there was a similar case, and they were saying, I would go with left thoracotomy because the tumor is all on the left side. This was another case they were discussing. And I personally feel that though the tumor is on the left side, the area that will get you into trouble is in the mediastinum. And if you go in with a left thoracotomy, you will never be able to reach the heart when things go wrong. And so that is why I personally prefer to do a sternotomy, because I have got ready access to the heart, I have got ready access to the pericardium. I can just open it and quickly go on bypass and salvage the patient. So this is not about tumor being on the right side or left side. I do not like to come from thoracotomy from the left side because the tumor is in your face. And when things go wrong, you cannot access the aorta, you cannot access the pulmonary artery. So it's very difficult. That is why I go sternotomy and then go laterally into a hemisternotomy. And then this is the sort of tumor that you take out. This is along with the lungs. It was involving the lungs, so we stapled the lungs. See this is a guy who's got a good outcome, who's not a good outcome. He's still got some hope. And so you should try and be radical with the resection. Try and take out as much as possible and try and get as close to R0. I don't think I got R0 in this because it was quite a large tumor and involving a few structures, but you must try and be as radical as possible. So what about lymph nodes? A lot of people ask this question, what should we do when we are taking out anterior mediastinal tumors? Should we do lymph node dissection or not? Any suspicious node should be removed. If you see a suspicious node in the pre-op PET, you must try and take out that. If it is stage 1 and stage 2, then just the adjacent and the anterior mediastinal nodes need to be removed. If it is stage 3, systematic mediastinal nodal dissection is mandatory because you need to stage this tumor accurately and you need to find out. Remember, I told you that the moment it becomes a lymphatic spread, it becomes stage 4. So you got to be very clear that you need to document this. And the nodes that we go for are the paratracheal, the aortopulmonary, and the subcarinal. These 3 stations have to be taken out in stage 3 thymomas, at least as far as possible. Stage 4, you try and take out as much as you can. Whatever you see, take out, including the supraclavicular and the lower cervical as well, because the tumor spreads to these areas. So lymph node dissection as a strategy in thymoma is a common question asked in the exam. It's a common MCQ in the exam where a lot of people will ask you. And now ITMIC is increasingly talking about lymph node dissection. So just doing a simple thymectomy is not enough. You must try and see if you can dissect some of the lymph nodes. It's okay in a stage 1A tumor, but the moment you go beyond that, you should try and get at least the representative lymph nodes from that area. Okay? SVC involvement. What do you do if the tumor is involving the SVC? In my case, I always try and give them, if I feel that this is going to need an SVC resection or an anastomosis, I'll try and give them preoperative chemotherapy. And that is also part of the guidelines, saying give them preoperative chemotherapy. First is discuss in a multidisciplinary tumor board. Give them preoperative chemotherapy, reassess, restage. So that means repeat PET scan, repeat CT scan, everything. And then see if the tumor has downstage. It's quite important to downstage the tumor. Don't just go in and operate. There are some times when we have operated, even with an SVC involvement, where we felt that the tumor was lobulated and localized. Though it was involving the SVC, we have felt that it was lobulated. And I felt that I could take it out, and then I would have given him chemotherapy. So it depends on the patient. If it's a very irregular margin and there's a lot of spread, then you give preoperative chemotherapy downstage and then you operate after repeat imaging. But there are occasions where there was localized invasion of the SVC with not much spread laterally. We've gone in, we've taken it out, and then we've sent for histopathology. And when the histopathology came back, we then gave the patient chemotherapy. And in some cases, we've also given radiotherapy in these cases. Okay, so it completely depends. And then you have to repair the SVC. The repair can be either, you just, if you've just taken out a sleeve, a small sleeve, then you just go in and suture it. So use a vascular clamp, sleeve the thymoma off, sleeve that anterior mediastinal tumor off, and just do a primary repair. That is possible. Sometimes you have to do an SVC to SVC anastomosis. So just a localized, so clamp and sew, you go in, clamp, take it out, do clamp and sew. Sometimes you have to, most of the time you have to go on bypass and then do a resection and then take out. You could do a left innominate to SVC reconstruction, or you could do a right IJV to SVC reconstruction. It completely depends on what is the level of resection. But the moment you get into resection of SVC, you must try to get R0 resection. This is the philosophy. The only reason why you're going into the SVC is to get an R0 resection. So I am very aggressive if I feel that the SVC is involved, then I want to get R0 resection. So I don't just wait for SVC to SVC. I'll do whatever it takes to clear it out. So this is the sort of re-anastomosis that you can do. You can clamp off, and most of the times you'll find that when these tumors have been invading the SVC or causing compression of the brachiocephalic vein and things like that, there is usually a lot of collateralization. So you can safely actually even ligate the left IJV on the brachiocephalic and take out the tumor and just do the main reconstruction on one side. And you don't need to worry about the other side because there is a lot of collateralization. So it's important to assess that preoperatively and then do whatever is needed. So this is, the right side being taken out and a reconstruction done on the left side. That one was on the right side. So whatever it takes, you just have to decide what it takes and then you do whichever reconstruction you can, the principle being R0 resection as far as possible. At least macroscopic R0. I'm not talking about microscopic, I'm saying at least macroscopic R0. So how do you do SVC resections? One is you can do direct clamp and sew. Yeah, you can just clamp and sew. 1 minute, let me just get this out. Or you could go on to cardiopulmonary bypass and get control of the heart and then go do this thing. Usually when you're doing SVC resections, I found that the right phrenic is involved. Very often you have to actually sacrifice the right phrenic. If you are sacrificing the right phrenic, you've got to be sure that the patient has got adequate pulmonary reserve, that he will tolerate one phrenic being resected. I usually do not sacrifice both phrenics because if you sacrifice both phrenics, they become respiratory cripples. And then you have to put in diaphragm pacemakers and all that. So I do not do both-sided phrenic resections. I will do only one-sided. And if I've done one-sided and I feel that he is slightly compromised in respiratory function, then I will go ahead and plicate that diaphragm. So on table, you make that decision whether you want to plicate or not. And really, plication is not such a difficult surgery. It just takes a few stitches to push the diaphragm down. So it's well worth doing it when you are operating on the patient, okay? Autologous vein can be used. You can use bovine pericardium. You can use an arterial homograft, or you can use a PTFE vascular patch. It just depends on whatever extent of resection that you have done, and also depends on what is available at that time in your theater. So this is how some of those techniques are done. It really depends. There is some literature out there of SVC resections, and still got few patients alive. There is this Chen et al. Who's done about 15 of them, and he's got 14 out of 15 alive at 35 months follow-up. So it is well worth it. It is a surgery that you must think about, and though it is a big surgery, but it's well worth it because you still might get 50% survival at 5 years. And if that's what you're getting, then it's worth it. What about stage 4A tumors? What do you do in a stage 4A thymoma? Pleuropneumonectomy has been recommended in some cases. These are very, very rare cases. Very, very rare cases. Now, let me tell you, pleuropneumonectomy is a very complex surgery with huge morbidity. Because what you're really doing in a pleuropneumonectomy is you are taking out all of the pleura, all of the lung, all of the pericardium, all of the diaphragm. And from our experience with mesothelioma surgeries, pleuropneumonectomy really is a very morbid surgery and is reserved in very, very few cases. So these are extreme cases I'm talking about. Most of them will have induction chemotherapy with localized pleural disease. And that's when we get into these scenarios. You do either by a posterolateral thoracotomy or a median sternotomy or a clamshell, hemi-clamshell, depending on which side you're getting into. You have to go extra pleurally, dissect all the pleura out. Once you've dissected all the pleura out, then you get the vein, the pulmonary veins, then you get the pulmonary artery, and you get the bronchus. And then you have to resect the diaphragm. Depending on whatever is involved, or you have to take out the pericardium as well. And once you've done that, then you have to reconstruct the diaphragm either with a PTFE. And always, if you've taken out a large patch of the pericardium, you must reconstruct the pericardium because you might cause cardiac herniation. Because the lung is out, and if you leave a hole on the pericardium, the heart will move to the other side, and you will get an acute cardiac arrest because of cardiac herniation. So if you have taken out the pericardium in these sort of scenarios, you have to reconstruct the pericardium. But you've always got to make it fenestrated, because the last thing you want is a pericardial tamponade. So you make multiple holes on the mesh that you're using. So this is a pericardial patch which is being repaired. This is a diaphragm. Very, very few surgeries which are done like this. I think the world has got very limited experience with this sort of pleuropneumonectomy for thymic tumors. And I think the biggest series is 5 cases where they still had people living at 5 years. So you got to be very careful about these complex high-risk surgeries. And you got to look at that. Some people have also done great vessels. So they've replaced the aorta. See this, the aortic arch has been replaced. They've replaced the brachiocephalic artery, the common carotid, and things like that. So a lot of people have pushed hard to beyond the boundaries of normal surgery. Look at this. This series is all about, the big, this is aortic resection, aortic arch, main PA resection. And really look at this aortic arch, but an R2 resection. I mean, really, that would not give you such a great outcome, because look at this, date of death was 7 days after surgery. So you got to balance things out. Yes, people do it, but you still have to balance it out. You need a live patient at the end of all this. Sternum, what about sternum and chest wall involvement? Sternum and chest wall involvement is definitely an indication. You must resect the chest wall. You must reconstruct the chest wall. You can do a sternectomy. You can do a chest wall resection. That's a whole chapter by itself, and I can talk about it at a later stage, where I can talk about how to reconstruct the chest wall. You can use muscle flaps. You can use mesh. Various types of meshes are available. You can use omentum to fill in the gap, or you can use sternal prosthesis. These are the newer type of sternal prosthesis, which are 3D printed, specific for the patient and specific for the disease. And this is one talk. I will give it in this series, reconstruction of the chest wall. This is a it's a large topic. But when you're dealing with thymomas invading, when you're dealing with anterior mediastinal tumors invading the chest wall, it is not a contraindication for surgery. If the patient is fit, you must do it because you have a good chance of getting R0 resection. And reconstructing the chest wall is no big deal these days. You have got a huge amount of prosthesis available which you can use to reconstruct the chest wall. As I said, all thymic tissue must be oriented on a mediastinal board. A digital picture of the specimen must be made. A sketch of the specimen is important. And very often you have to put stitches on the specimen to tell the pathologist where is what. So you have to, sometimes you've taken the phrenic, you've got to put a stitch there and label it, you know, phrenic is here. If you've taken the pericardium, you've got to take a stitch and leave it there for the pathologist to know. And also the orientation, they have to know the orientation. This is the thing in the neck, this is the tail in the neck, this is the pericardium, all that you have got to label very carefully. Something like this, okay? So this is a thymic board that you put the specimen on it and you label it. And you tell this pathologist specifically. So the specimen goes with the thymic board in the background, and then the pathologist looks at it. This is strongly recommended by ITMIC. ITMIC is talking highly about using a thymic board for all thymic surgeries. And a sample thymic board is available on the ITMIC website. So go to itmic.org and you can print out that thing and use it in your clinical practice. Okay. So yeah, these are tumors which should be treated aggressively. Surgery still remains the mainstay of treatment. I personally think smaller tumors are amenable for VATS. The cutoff, they say, is 5 centimeters, but a lot of people are pushing the boundaries. You have to be careful about what is the outcome. It's not about the size, it's about maintaining the integrity of the capsule. If you breach the capsule, you are in deep trouble. You are causing a stage 1 tumor to become a stage 4A or a 4B tumor, and that is something that should be there in your mind. So it's not about the technique, it's about what is best for the patient. If you do operate, make sure you do non-touch technique. I am not a fan of thymomectomy, but there are a lot of people out there who do thymomectomy and they swear by it. The important thing to remember is these are slow-growing tumors. And you may operate on the patient and go away, but the recurrence will happen after 5 years. And that's a disaster for a young patient. That is not something that you want in a young patient. So you may think that you got away with taking out a big tumor. I did it robotic, fantastic. But 5 years down the road, he's going to come back to some other surgeon and that will show the recurrence. So it's quite important to understand. In advanced stages, it's got to be multimodality therapy. Preoperative chemotherapy for downstaging is an accepted protocol. You must use chemotherapy for downstaging and then restage. You should not operate without restaging. You have to restage the tumor to make sure that it is operable or it is within the limits of surgery. And even if it's a stage 4 thymoma, it is worth giving the patient a chance for survival, because as I showed you in that stage, 5-year survival at stage 4 can be 50%. Some of the papers are talking about 50% 5-year survival. So you really as a surgeon need to push the boundaries and push the tumor board to make sure that you operate on these patients. Thank you. I have not gone into details of PET scan and, not at basic level. This was a more advanced level lecture to talk purely about techniques. I'll take questions now. Anybody who wants questions. You can switch your microphone on and ask me questions.
Sir, I have a doubt, sir.
Yeah, who's that? You have to first identify yourself because I've got so many people on, I don't know who's asking.
Sir, this is Pradeep.
Sorry, who is that?
Hello, this is Pradeep, sir.
Pradeep, yeah. Pradeep from where?
Sir, I'm from AIMS, New Delhi.
Ames, New Delhi. Yeah, tell me.
Sir, you told about the pleuropneumonectomy, and if the tumor is a stage 4A, where it is involving only the parietal pleura and the surface of the lung, is it recommended?
You know, there's very little experience around the world with pleuropneumonectomy. It's only very specific cases. I'll tell you, if it's a young guy,
Yes, sir.
25, 30-year-old guy who has had his chemotherapy, the tumor is still there, and he's really, there's nothing else to offer him, I would offer him pleuropneumonectomy. So it's not, don't get hooked onto pleuropneumonectomy. It's not it's a surgery which should not be done.
Okay.
You got to be very careful about it.
Recently, we did a case and came out with a wedge resection. So it was involving a part of parietal pleura and lung.
Yeah, you can do that. You can do selective wedge resection and then give. Nowadays, the radio and chemo regimes have become better. In the older days, they were not so good. So you try to do your best. But very little experience around the world with pleuropneumonectomy for thymoma. So it is only very specific cases where the patient twists my arm, where I have done it. I can only remember 2 cases where I did a pleuropneumonectomy for thymoma. Not very common. And very often you just do a localized resection and come out and give post-op chemo.
Sir, what about in stage 4B? Can you do, suppose if it is like involving one side, it's a very hypothetical.
It depends on how well you have managed to downstage it.
Okay.
It depends on how well you've managed to downstage it. The key is not the first staging, the key is the second staging. So if you manage to downstage it, there's nothing you can do about it. I mean, doing a debulking surgery is not, I don't go in with an idea that I will debulk. I only go in if I think I'm going to do R0 or at least R1. But, you've got to be careful about that. You don't want to, if it is downstage and he has reacted to chemotherapy and the second staging came back as 3A or something like that, I will do it. It depends on individual experience as well. A lot of people won't do it. They will say, thank you very much, bye-bye. But you know what happens? These are young people. They are 25, 30-year-old with a wife, one child. And, they have no other option. And if I say no, then nobody will touch this patient ever. So you have to think very carefully. So sometimes you are pushed into it because for other reasons rather than clinical reasons. And the patient, even if you give him a mortality of 60%, you'll tell him there's 60% chance he will die. He'll say, okay, there's a 40% chance I will live. So he will take it. It's a very difficult discussion with family and the patient. Very, very difficult discussion. But you must try and give them a chance. That's my take on it.
Okay.
Yeah. Who's next?
Sir, I have a doubt, Vikas here.
Yeah, hi Vikas. How are you? Good to see you, man.
Sir, how are you?
Is the beard there or not there? I can't see, man. Is the beard there?
Smaller, sir, now.
Smaller, no wonder. Tell me.
Sir, do we know pre-operatively it's a thymic carcinoma or know it only after histopathology?
Most of the times it's after histopathology. Very few, thymoma is a very complex histopathology. And I personally have had a lot of problems with preoperative true cut and FNAC. And we had a patient who had a chemotherapy, young guy, 22-year-old chap who had a mediastinal tumor, and they did 3 biopsies. And 3 biopsies all got reported as thymoma. All of them got reported as thymoma. And we offered him surgery and we took it out. And eventually the final specimen also got reported as thymoma. And then they sent it for quest to the US. And the US said there could be elements of lymphoma in it. Or it could be a thymolymphoma or something like that. And then he went to the US and he got treatment and they told him, he should have never been operated. And he sued us, The pathology for thymoma is very complex and you really need a good, strong pathologist who can tell you clearly that this is thymoma. So the issue with thymic carcinoma, again, the pathology you're taking is true cut, man. It's tiny and they cannot comment on it. So very often you end up going in, doing what you want to do, and then the histology comes back as carcinoma. So, but with the new IHC and all that, they are able to, if it's a good pathologist, yeah. In India, I sent to Anita Borges. She's very good. So it's a real problem. Thymic pathology to report for a pathologist is a real problem.
Sir, one more question. Sir. If you have
Yeah,
a young,
who is it? Yeah, Vikas, yeah, tell me.
you have a young male around 40 years old male, anterior mediastinal mass. So what is the typical chemical investigation you will ask after you have got a CT scan, anterior mediastinal mass? So what is the biochemical investigation you will do?
Because honestly, this is a clinical case. We should discuss it as a case. I want one of you to present this case to me, and then we will discuss the management. Is that okay? Because really, this is a very important clinical case. Almost all of you will get it in the exam. So I think next time when I do, remind me. I'll give you a clinical scenario, and then you do a clinical case presentation to me. And then it will be a much more interesting discussion of what next. Okay? So let me not give all the answers out at this stage. Let's do a clinical case with you guys. In fact, you present to me. If you want tomorrow, you just take a anterior mediastinal tumor and present to me the case. It doesn't matter. Make an imaginary case. It doesn't matter. And take a CT scan of that picture, or I'll get a CT scan tomorrow. You present one hypothetical case of an anterior mediastinal, and then we'll discuss, and everybody will learn from it. How to investigate an anterior mediastinal mass. It's very important. So good question. Always it will come in the exam. I promise you that. Anterior mediastinal mass is the commonest case that you get in the exam. You get lung pathology, you get anterior mediastinal mass, you get TB. These are the common ones that come. So let's discuss it as a clinical case. Is that okay? If you want, you can present to me tomorrow. I am at home tomorrow. So same time you can present to me. Yeah.
Sir, Manjunath here, sir.
Hi Manjunath, how are you?
I'm good, sir. Sir, my
Manjunath,
question was...
Before you ask me the question, you have to get the credit for this teaching session.
No, sir, the credit for you, sir. It was just my...
No, because you stimulated me. I am ready to teach anytime, provided you people ask me.
Yes, sir.
If you don't ask me, then I can't force myself onto you guys.
Yes.
Okay, good.
Sir,
Tell me, Manjunath.
My question is, if there's a anterior mediastinal lesion and if patient is myasthenic, should we just consider this as thymoma, or should we still consider doing a tissue diagnosis?
I think common things common, it will be thymoma. But common things common, it will be thymoma. Sometimes if it's a stage 1 thymoma, I don't do a FNAC or a tissue diagnosis. I just go ahead and resect it. So it depends on the size of the thing. If it's a large thing or things like that. But usually myasthenics, I don't want to put them through more things. I just take it out because they will need thymectomy anyways. And we know that anybody with a thymoma has a higher chance of responding to surgery. You know, when you get a patient with myasthenia and you talk about thymectomy, the discussion goes as 33% chance you will get complete remission of treatment, 33% chance that you will stabilize your medication, and 33% chance nothing will happen and you will continue to progress. And so if you're thymoma, if you've got a lesion there, you're more likely to fall in the first 33%. First or second 33%. So that's why you just take it out. Because thymectomy is therapeutic in 33% of patients. So 1/3 chance.
Okay, thank you.
Sir, excuse me, for the myasthenia patient, if you do thymectomy and we don't have thymoma, would you still need to be careful to do it non-touch technique, or?
Yeah, the non-touch technique means that you handle only the fat and the thymic tissue, not the thymoma. So if there is no thymoma in a thymectomy, it doesn't really matter. So you just handle the tissue gently. You've got to be gentle with it. I hate it when surgeons macerate the tissue, or I've done it a few times. I promise you, sir, a couple of times when I was doing a anterior mediastinal mass, particularly when it was in the angle of the pericardium. In fact, the last robotic case I did with Bhushan, we had great difficulty into getting into that angle. And I think we must have damaged the capsule for sure. So it has happened even in my hands, and many, in fact, I was almost on the point of converting. I said, enough, I can't deal with it, let me convert. And then these young boys pushed me saying, no, sir, let's do it. So we managed to finish it by robotic. But you don't feel good when you're not handling tissue in a good way. You've got to be gentle with the tissue. So I prefer to do open surgery and convert to open if it's in the benefit of the patients. Sometimes it takes more maturity to know when to continue.
That
So
patient is doing fine.
good, but I was almost on the point of converting. You remember, Bhushan, the last case? It doesn't make you feel good as a surgeon when you're macerating the tissue or you're making a mess up. You know, it's not good.
Yeah.
Okay, next. Next question, guys. Are we all done? Bloody hell, 2.5 hours you've got me teaching, huh? That is not bad, yeah? Okay, all right. So I feel that I've done some good to the world on this corona problems. Okay, thank you very much. All the best. And we'll see again. I might give you a short notice and I might come online. I've got a few patients lined up tomorrow, but I think they may all cancel probably. And if they cancel, then I'll give you a notice like this around the same time, 10:30 in the morning, UK time. I will give you a notice, and tomorrow we can discuss management of locally advanced lung cancers, the guidelines.
Okay.
It's quite important to know those guidelines. And I prefer to do it like this, that one basic science and one complex issue. So at least we will cover a lot more. If Vikas is ready, he can present the case to me. We'll talk about how to investigate a anterior mediastinal mass. And Vikas knows I'm not, it is purely educational. So don't worry about it. Just whatever you got presented. Yeah,
I will
present it,
prepare.
and then I'll talk about guidelines for management of locally advanced lung cancer. You know, what are the ESMO guidelines and what are the other guidelines? Okay. Thank you very much, guys. Good day to you. And
Thank you.
I hope you enjoyed it. I hope this is the way of the future. I think increasingly, I feel you know now the guideline has come out here with the GMC as well, that all consultations should go teleconsulting. I've been doing it for 5 years. Nobody believed me, but now I'm very happy that the rest of the world is coming around to this. It's very good. Yeah, you sit in your home with a cup of tea in front of your computer, and the money comes in your bank. What else can you ask for? All right. Okay. Thank you very much, guys. I'll see you.
Thank you.
Bye-bye.